Hey! Welcome to my talk on cardiac arrhythmias and conduction blocks in small animals. This is something that I feel I struggled with on rotation, so I hope you learned something new and enjoy the video. So I'm going to start with the basics of analysing an ECG, just as a little refresher for you. So number one, what is the rate? Is it bradycardic or tachycardic? Number two, what is the rhythm? Number three, is there a P for every QRS? And is there a QRS for every P? It's number four. And number five, are these complexes related? I'm not going to go over very much of the basics of an ECG, so if you need to look this up, please go and look at another video first. So here I've just drawn a little ECG trace on the left, just to refresh your memory, and then a diagram of the heart on the right. Obviously, you know, deoxygenated blood goes into the right side of the heart through the vena cava, into the right atrium, right ventricle, and out through the pulmonary artery. It then gets oxygenated in the lungs and goes back into the heart through the pulmonary vein, left atrium, left ventricle, and out through the aorta. I've just drawn on the sinoatrial node and AV node for reference. So I'm going to talk briefly about sinus arrhythmia. So this can be a very normal finding in dogs, and it's referred to as a cyclical variation in the RR interval, and it may or may not occur with breathing. So I'll just draw a little ECG for you here. As you can see in my ECG, the middle four complexes are much closer together than the outer ones. And this is kind of what sinus arrhythmia looks like. And the reason it's called sinus arrhythmia is because it originates at the sinus node or the SA node. Remember, there will be a P for every QRS and a QRS for every P wave. And there is this cyclical variation in the RR interval. And remember, like I said before, it may or may not occur with breathing. It's normally associated with an increased vagal tone, and it may be a normal finding. However, there are also abnormal causes of increased vagal tone, which I'll just go through now. First one, CNS disease. Second, upper respiratory tract disease, for example, in your BOAS patients and your brachycephalics. Third, increase in intraocular pressure. Fourth, an intrathoracic mass. And five, gastrointestinal tract diseases. So now I'm just going to run through the types of AV block. So there's first degree AV block, second degree AV block, type 1 and type 2, and then third degree AV block. So obviously we're going to start with first degree AV block. And this is defined as a prolonged PQ or PR interval, more than normal. I've highlighted it as the little red lines. As you can see, there is still a P for every QRS and a QRS for every P. And it can be a normal finding in dogs with high vagal tone. But it can also be an abnormal finding in dogs with high vagal tone as well. And like I said before, vagal tone can be increased in diseased animals, e.g. those with CNS disease, GI disease, increased intraocular pressure, an intrathoracic mass, and drugs can also cause an increased vagal tone, such as digoxin. Now we'll move on to second degree AV block, type 1. Now in second degree AV block, it means that some of the P waves aren't conducting, so it's being blocked at the AV node. And obviously, remember, this is split into type 1 and type 2. So let's talk quickly about type 1. In type 1, the PQ interval increases and increases, and then suddenly there's a dropped beat. So I'm just going to draw a quick ECG for you, just to show what this looks like. Here I've drawn in most of the P waves. I did forget the one by the question mark, oops. But as you can see, the orange lines represent an increasing PQ interval, and then suddenly there's no QRS complex. So there will be a P for every QRS, but there won't be a QRS for every P. And again, this is seen in patients with increased vagal tone. So think, is this physiological or pathological? There will be no clinical signs if the dropped beat is not happening very frequently. So now we'll move on to second degree AV block, type 2. I'm sorry, I didn't mean to go quite so much off the screen. Anyway, it looks a bit like this, and I've drawn in the P waves to help you. In type 2, there is a relationship between P and Q. In fact, it's constant. But some P waves do not lead to QRS complexes, as you can see by the question marks. This is normally in a cyclical fashion, so it tends to be represented as a ratio, for example 2 to 1, e.g. 2 sinus beats to 1 block beat. Second degree AV block, type 2, is never normal. The causes are normally idiopathic degeneration and fibrosis of the atrioventricular node, and sometimes it can be caused by myocarditis or neoplasia, but these tend to be pretty rare. The clinical signs really depend, like I said before, on how frequently the blocking is occurring. But if it's more frequent, then you'll get signs of lethargy and syncope, and sometimes cardiac heart failure if it's really bradycardic. So now we'll move on to third degree AV block. And this is where there is no association between the P waves and the QRS complexes. The P waves and the QRS complexes are very independent of themselves. This means that whatever the atria is doing is not causing depolarization of the ventricles, and it's seen by this big, wide, and bizarre complex, as depolarization within the ventricles is taking a really long time. Remember, they're independent atrioventricular and ventricular activities. I've just redrawn it again for you to make it a bit clearer. Here are the complexes are wide and bizarre. There tends to be a bit of a constant P rate, and there is no relationship between the P's and the QRS complexes. When the ventricles are depolarizing themselves, we call these ventricular escape beats. And in the dog, this is 20 to 60 beats per minute. And in the cat, this is about 60 to 120. So remember, this will be very bradycardic if you're listening to this. So the causes of this are very similar to second degree type 2 AV block, including idiopathic degeneration and fibrosis of the AV node. Clinical signs include lethargy, syncope, and cardiac heart failure. Now I'm just going to briefly talk about sixth sinus syndrome, which tends to occur in Westies, so excuse my very poor drawing of this poor little dog. But it's a term for a collection of arrhythmias, where the sinus node, or the SA node, just doesn't fire off at a correct rate. So I'm just going to write that down here. Sinus node does not fire off an impulse for the heart to contract. This will cause bradycardia, a sinus arrest. I didn't mean sinus bradycardia, sorry, and runs of tachycardia. If the heart stops for longer than 8 seconds, then the dog will collapse. It can tend to look a bit like seizures, so care with your differentials here. Here I'm just drawing a very bad sausage dog. Excuse me for my poor art. But Dachshunds, as well as cockers and miniature schnauzers, all tend to be affected by sixth sinus syndrome. Remember to look for other parts of the myocardium generating the impulse. For example, those wide QRS complexes. Now I'm going to move on to supraventricular premature complexes. Now these are complexes originating above the ventricles, as the name suggests, and happening prematurely. So as you can see, the third beat and the sixth complex that I've drawn are premature. I'm just going to draw in some little arrows to help you and circle the ones that are premature. So that red arrows show the shortened RR interval compared to this green arrow that I've drawn, which is the regular sinus rate. So these originate elsewhere in the atria, other than the sinus node. So I'm just going to draw a little diagram to help depict this. And sometimes, because they're originating from the left side of the heart instead of the right side of the heart, the P waves can become negative, like what I've drawn in these premature complexes. Remember, the QRS complexes are still normal and narrow, because once the impulse is getting down to the ventricles, it's depolarizing the ventricles very quickly. So causes of supraventricular premature complexes include atrial dilatation and any disease causing that, structural atrial diseases, I forgot to mention the irregular RR intervals, structural atrial diseases, and any autonomic imbalance, for example, increased sympathetic drive and parasympathetic drive at the same time. Sometimes these complexes can be so premature that you won't even see the P wave because it will be buried in the T wave of the complex before. So look for these ectopic P waves. Now I'm going to talk about supraventricular tachycardia. And again, supra meaning above, so above the ventricles, and tachy meaning fast. I'll just draw a little ECG to help you see what they look like. Excuse my really awful pen. Anyway, I've tried to draw these 5 complexes close together, and this is the element of the tachycardia. So I'll just write sinus, rhythm, tachycardia, and more sinus rhythm at the end. As you can see, the RR interval is incredibly shortened in the middle. The QRS is typically still normal and narrow, but there is this shortened RR interval, like I've just mentioned. The heart rate tends to be really high, so we're looking at between 200 and 300 beats per minute. And the causes include atrial disease, dilatation, structural atrial disease, and autonomic imbalance, like before with the supraventricular premature complexes. The clinical signs: syncope and lethargy. Imagine if your heart was going that fast. Remember, the shortened RR interval is just more than sinus rhythm. It can also be caused by a thing called the bypass tract, which we'll just touch on quickly. Now, the bypass tract is basically where there's a muscular connection between the atria and the ventricles, which causes the impulse to short circuit. Now, this impulse can go up or down through the bypass tract, as I'll just draw on now. The red dots obviously represent the SA node and the AV node. And here's my little bypass tract in green. So the impulse can go down or it can come back up. And this causes runs of supraventricular tachycardia, as you can imagine. Now finally, I wish it was that simple in cardiology, but instead of calling it supraventricular fibrillation, we're going to call it atrial fibrillation. Now this looks something like this. There is a complete lack of P waves and this irregularly irregular rhythm. There may be this wobbly baseline, which we call F waves, but the absence of F waves does not necessarily mean it's not atrial fibrillation. I'm just going to draw the wavelet theory that really helped me remember what atrial fibrillation looked like on an ECG. And this is where there are tiny little wavelets that are all originating from elsewhere in the atria, other than the sinus node, and they're causing these random depolarizations of the ventricles. And that's where you get this irregularly irregular rhythm. Anyway, I thought it was quite a nice little drawing. Fortunately or unfortunately, my Wi-Fi wasn't strong enough to upload the ventricular arrhythmias, but here's a little summary of the conduction blocks and sinus arrhythmia. So with sinus arrhythmia, there's a cyclical variation in the RR interval. First degree AV block, there's a prolonged PQ interval due to increased vagal tone. Second degree AV block type 1, there's an increasing PQ interval and then a dropped beat. Type 2, there's a constant PQ interval but intermittently dropped beats. And in third degree AV block, there is no relationship between the P and the QRS complexes. So look for those ventricular escape beats. Thank you for watching. I hope you enjoyed this video.